presentation. I'm delighted to have collaborated with Kevin Pottie on the presentation on the work that he's presenting on today, which is how to approach a realist review in primary care. So this was a realist review that was done specifically for the purpose of informing transformation in a region. So that was a very interesting learning for me. I think a lot of us know of Dr. Pottie's work on a previous project that was called Impact. So you've worked on two separate impact projects, which was the integration of the pharmacist, and worked with Bruyère in the integration of pharmacists in primary care, and that's been a study that really sort of helped ground the integration of interprofessional teams into primary care, at least within Ontario, and much broader, and led to a lot of other work related to this. And most recently, I think Dr. Pottie's research area has been on migrants and vulnerable population, always on vulnerable population. He served Canada on the 5-country migration initiative, the European Union ADAPT Migrant Health Group, the Canadian Task Force for Preventive Healthcare, and the Cochrane Equity Methods Migrant Subgroup. So a lot of us are aware of his work published in CNAJ on how to manage or screen refugees and recent immigrants. So that's been some landmark studies there. He has a CIHR-funded immigrant supplement. Not sure, okay? That's kind of a standalone sentence there. Maybe you can enlighten us on that. He's a family physician, associate professor, and researcher in the Bruyère group here. Welcome.
And I think our process is, and thanks for the invitation to present, but really it's not just me presenting, but I was the only one that sent the bio and picture. So I think next time I'm going to have to check to make sure my team is sending in their bio and picture as well, because we have Simone, Danielle, and Micere, and Pauline, so a whole bunch of people. As this was really a team effort, it's been going on for a while, and it's also linked with our Australian team, which Simone is leading. So next time I should be slower to send in my, my material.
We don't all have nice professional pictures like yours. They're really good.
So no, I'm just joking, but it's a pleasure to get to present on this topic. And Vivian Welsh, who isn't able to be with us, as well as working with us. And Vivian and I have worked on this method in the past. And I believe this is incredibly important for family medicine, where you have a lot of complexity, a lot of contextual factors, and we're always wondering, not just whether it works or not, which is important, but why, when, how, where. And these are the kind of questions that play out in primary care. And in the Impact Project, we're trying to develop interventions that will improve the care for disadvantaged or vulnerable populations. So I originally, my challenge was to use the ripstick within the presentation today. So that's coming up. Next slide. How do I?
Oh, you haven't quite.
Oh, I do the slides.
Yeah. You're in control.
Okay. There's all the other presenters. We've said. I think, yeah, so really this presentation, my job is to give you a little bit of overview, and then we're going to have 3 realist review examples that we've been working on. And we're actually in the process of finishing these and doing the final analysis, so hopefully we can have some questions and discussion. Just need to make sure we're on the same page. So when we're looking at we have a research question or a problem within our practice or within a research setting, we will always want to go to what's already been published. We want to build on the scientific foundations that exist. Historically, there was a literature review. In the evidence-based medicine movement has kind of put that, I'd say, well, you can't just do a literature review and put down your favorite authors every time. So you should actually have a research question, and then there's been several different forms of what originally we might have called a literature review, but now have been called different things, such as a scoping review, which is, again, it's a research question-based systematic search, but then maybe a thematic reporting of what's found in the literature. So that's a scoping review. Cochrane review is, people often probably have heard of these, and they're often related to effectiveness. Let's just say for a medication or an intervention, and you report the benefits and harms, and you search all of the literature with often a focus on the highest quality, randomized controlled trials, but potentially other prospective trials. That's for the, whether something works. But as we know, in Cochrane has always been criticized for this exact thing. Well, that's very nice, but will it work for me in my setting, in my constraints? So I think this is where Cochrane reviews have definitely a good starting point, but then you want to know whether it works. The other reviews that have become very important for policymakers and other stakeholders is the cost effectiveness review, which is just another example of where people often really want to understand the cost. Now, there's cost effectiveness, there's resource use, there's cost, and there's affordability. So that field actually is enlarged into several different things, but I think these are not for today. And then the realist review, which is not new, and I brought the realist evaluation Ray Potson McTilley book. So I kind of feel like this is one of probably the top 2 or 3 books that really launched this field. Ray Potson is often cited as one of the originators for this method. And so, and from the UK, but I think a lot of people have found it very useful in their leadership. Trish Greenhalgh, who is a kind of a GP researcher, has actually used this method a lot and published in B&J and several other high-level journals with this method. So that's always nice. So the concept is that there's a pathway for effectiveness, and it's not necessarily always the same. When you try to answer questions like what works when, for whom, in what circumstances, you realize that you have to start dissecting what we often would consider, often the first step is to say, well, what is the theory behind the intervention? How does something, maybe might it work? And then we want to identify the mechanisms and the context which are interacting, there's an interplay with the intervention en route to certain outcomes. And one of the things that's a little bit different about this review is that we don't just care about the successful reviews, the successful studies that exist. If we just looked at total success, we would potentially not find the variation that we need to try to, in our analysis, to understand what other circumstances. And so we don't want to look at poor quality studies, but we definitely are not looking at, we don't just need like successful studies that show an intervention works. So I think that if we want good quality studies that maybe show no result or show negative or positive results. And that's, I think, that's quite important. So I think do people, maybe not everybody knows about the Impact Research Program, but I think it's important. It's a 5-year team grant, Australia, Canada, international grant, and Simone is one of the PIs that is emerging, and I really think it's a fun project to work on because we have 3 sites in Australia and 3 provinces in Canada, or sites in Canada, and we're trying to kind of follow a similar method as there's a development of interventions for primary care. So one of the pathway en route was a realist reviews. So they've now done 3 realist reviews on topics that interested their LIPs, which means local
innovation partnerships, so the region, the stakeholders in the region.
Yeah, so each has regional stakeholders have put forward what they really would like to address in terms of an issue or research question, and there's been a lot of negotiation and collaboration at that level. And then they've come back to kind of a little bit more of this technical team to try to do the review on the existing literature that might be related to that intervention, en route toward developing an actual, implementation of an actual intervention. So it's priority development, priority tailoring, and I'm using this realist review as the background. Is that about? And I think people can ask questions at any point, but actually I'm not sure if that's okay.
Yeah, it's whatever format you like, Kevin, it's fine.
And so the idea was, and we did this with diabetes in immigrant communities a few years ago, and it was the idea was help. It actually is often an educational process just to go through the review with your stakeholders to understand the reality of what can be accomplished or not accomplished, and what other people have found. So I've always found it to be you can't always have the perfect studies or the perfect findings, but you can actually know what other people are doing, and I think that gives a little bit more understanding for feasibility and for other levels. The process was deliberate forms, as we talked about, where we, I think we spent a fair bit of time at the beginning really trying to work with the local partners and stakeholders. And then that to develop what we needed for our approach for a realist review was a research question. And then we used something called the logic model. Some people might think of an evidence chain or some understanding of how things would work. And that actually will then inform often the search strategy. Because we will often want to do a systematic search strategy that is informed by those two elements. So the logic model also just kind of helps things identify outcomes, and it's kind of like the PICO question, but it's not maybe as focused as a Cochrane PICO question. And there's different ways to do realist reviews, just to acknowledge. There is, let's say, the more systematic review approach, where you rely more on the published literature, and there's more, which I think a lot of realist reviewers would, I think people would always like to do, but when you actually go in and you do, say, stakeholder interviews, qualitative studies, you can actually do your own primary collection of data to inform existing data. And so in our situation, we really didn't have the time or the money to do the de novo collection, except for the working with the stakeholders. We weren't able to go do a sample of people of Montreal and ask them what they thought. But a lot of the realist reviewers may actually want to do that. So they would work really closely with their community, combining the existing evidence with local evidence, always en route to understanding how the mechanism or the things that are changing during intervention play in the context. And that's the objective. And then when we finally get down to what we had, which was 3 reviews, and I don't think I'm going to talk about the details. They're going to mention what we found in those reviews. So that's. I think this is a good. A lot of science is based on foundational work, and I don't think in the primary care field or a lot of the medical field we're quite as astute at saying, well, what was your theoretical framework? When we do PhD or social science research, theoretical framework is the holy grail, and if you don't really know what you're working with, it might be you could certainly go off base and not be following a certain method. So I think that we decided to use something called REAIM as a bit of a theoretical framework, because it dealt with primary care, access, stakeholder engagement, and we wanted to look at the studies and see what they could give us information on in terms of the REAIM framework. So it's a bit like what we call a framework analysis, rather than say an analysis just from looking for themes and trying to identify. We might actually start with some themes from an existing framework. Stop. I think I'm almost done.
It's the same thing.
Oh yes, so that just shows how it makes it together like a puzzle almost. So, and this, I think it was like a puzzle when you had like the 3 sites and 2 countries involved, and trying to get people following the same methods, and now we're trying to have checklists for quality for all 2 countries. It's actually not that difficult, but it requires another level of thinking all the time. Our coordinating, timing, meeting resources. So it's like basically doing 6 reviews at the same time. It's a little challenging, but it's been rewarding because we've learned and we've helped each other. So I think that's all I'm going to say with this, but the realist review has not always been well understood review. And it's not the easiest to get published, I have to say, because I've experienced this and I've heard this from other people. Like I said in summary, I believe in family medicine, it feels like the kind of review we should be doing, because I believe we have a lot of different contexts we're working in, and we don't always have the published articles in their current form answer the questions we need. So we may have to look at those articles in a different perspective. And certainly this is publishable, and lots of people are publishing realist reviews. But
so maybe before we go to the next step, we can ask other people have questions about what is a realist review. I mean, it's often used for complex intervention. You won't do a realist review for a medication, right? For something very straightforward, or you see a specialist. Or, anyway, so it's for more complex intervention. So do folks have questions about what that is?
I'm just wondering if you could just sort of explain again how this differs from a scoping review. What would distinguish it from a scoping review?
Good. That's a very good question.
Because I'm not clear in my mind, so I was just wondering whether or not you guys have grappled with this, because I think that there's that similarity in the actual methods, the approach. Because in a scoping review, you can deliberate with stakeholders, and you typically come back to them. So I'm just wondering if there's a bit of a blur between scoping review and this.
Yeah. No, I think that in some ways the scoping review is, to me, the new literature review for grad students. I mean, you really can't be doing anything without doing a scoping review, and you really probably aren't going to do a Cochrane review very often in your first part. So, and the literature review doesn't have the same credibility anymore. But very few people will be doing a realist review at the grad student level, just for example. And scoping reviews, I think, it can have different ways that they can be done as well, but I think, I like to think that the research question and identifying some level of theory and search terms, and then a systematic way to actually select your articles and synthesize them. So this is where it's actually looking fairly similar to what we did. But the realist people are very focused on mechanisms. And mechanisms are when an intervention starts, there's going to be a mechanism is what changes. So basically the idea is that when you do something, something else happens. When you do something else happens. And so when you implement an intervention, there's going to be these things changing. And this is changing within the context. So in primary care, it feels, for me in my mind, really easy to picture this. But I think in life it's not so difficult that you can't just expect drugs are the kind of slight exception, but still things happen, right? So you have side effects, or people run out of money, or people have something happen to them. So there's things that happen. So the realist people, and then there's the concept of outcomes. And they don't limit to certain outcomes, but rather how do these two interacting contexts and mechanisms lead to outcomes that are either successful or less successful, and from that you can deduce a sense of what are the kind of
the W5.
Some people call them rules.
Where, why, for whom.
But what some people talk about, I'm hesitant because I've noticed that there's a little bit of breadth in this field, and it's not, Ray Fawcett was here, we might have something else to say. So it's always like this a bit. But I really, some Trish Greenhalgh would call these actually almost rules. So we're trying to deduce, let's say, a few simple rules of the mechanism context interaction that can be utilized within, let's say, the implementation of an intervention. So that's the idealistic approach, and that's what Trish has done several on this, and she often talks like that. And I think that, whereas the scoping review, I don't think actually goes for the rules. It doesn't go down to that level of simplicity. and it actually often, depending on the subject, meaning more thematic based, and it certainly doesn't have mechanisms as the only theme. Like it may take on, I think it depends on the research question. So I think the scope review has a little bit more flexibility in my mind, so it can take on more topics.
Okay. So just in the interest of time, how much time have you guys each, like, have you given for each? So 8 minutes, 7 minutes, sounds good? Yeah. Oh, yeah, just to leave time for the discussion. Okay, so Michelle, let's go to Montreal.
Yeah, let's go.
I guess. Montreal is actually in the black marks, I think. I think I'm going to step through the black marks.
Thank you. Hi, I'm Micere. This is the picture. I don't have a bio right now, but soon. So we're going to, we did a realist review on Montreal, and I'm going to use the word LIP maybe a couple of times. If it's local innovation partnership. Okay, so the local context in Montreal is that there are a lot of unattached patients in the centralized waiting list, and it can take almost 3 years or more to get them attached to a family physician. So the focus of the review, so they would like to, in order to fill that gap of attaching those patients, they would like to involve a community health worker who will come and sort of act as a mediator between the patient and a family physician, who will probably accompany them to appointments or help them follow up with doctor recommendations, and well, your basic community health worker role. So they asked us to do a realist review that would identify the roles and activities of a community health worker and their benefits, and sort of to see what they would need to implement in order to make the intervention successful, or what they would like, what they should consider. So we identified 493 studies and included 10 of them, of which is a mix between systematic reviews and RCTs. So what do I press?
So right button, the middle right.
So from the literature, we identified certain patterns, and out of these, we had 4 themes that came about, 4 main themes. And the first one is that training impacts the effectiveness of intervention, meaning how the community health worker is trained affects the intervention positively. We realized that those who had like booster sessions did better than the ones who had a one-time training. And sorry, my legs are shaking. I don't know why. I'm so nervous. It's ridiculous.
Everybody knows
but
this
just
better
keep
than you,
going.
so.
I'll try and get to the end as fast as I can. Okay, so another thing is building the trust between the community health worker and the participant. That was a vital thing in making the intervention effective. So, okay, I lost it. Yeah, so the trust between the community health worker and the participant is vital to the intervention being effective. Another thing was the community health worker would need to share certain similarities between the participants and rather the patient and the doctors. I mean, with the patients, meaning they would have to come from probably the same community, speak the same language, which is a key thing to the trust they would have between the patients and the community health worker. So those two are sort of interlinked. And the last one is the outreach methods, how the community health worker deals with the caseload, for example. We realized that the ones that probably use the manual way of tracking their patients and probably recruiting them and following them up were not as effective as the ones who had electronic methods, and probably were technology savvy, it was easier to track their patients, and we found that the ones who used the manual way actually lost some participants in the process because they couldn't keep up. They couldn't follow them up as needed. So I think I've touched on everything I need to for the
Can I ask a question?
Yes,
Thank you, this is very helpful. It seems the mechanisms seem to be mostly on the side of the patient. The barriers, the patients, for whatever reason, are having trouble negotiating, finding a family doctor.
Yes.
Is that correct?
That's correct, yeah.
The doctors are also.
Oh, yes, the doctors are reluctant to take them up as well because of certain vulnerabilities that they would have. And so they're hoping that the community health worker would sort of, I give you the polite term, but yes. Yes.
So you mean the doctors are cherry picking and they're taking healthy people who speak French and all that kind of stuff?
Yeah. But it's mainly because the barriers that they face makes it difficult also for the patient to keep up. For example, maybe transportation and they can't get there, so they don't keep appointments or they don't speak the language. And I know the community that probably is being looked at has a large amount of immigrants as well. So there's a whole lot of other things to consider.
Just one of the contexts in all of Quebec is that there's been a law or an agreement between the Doctors Association and the government that the doctors have agreed to accept many more orphan patients, otherwise they're going to suffer a wage cut.
And that is
and so that wouldn't make much difference then to these vulnerable people.
So this started, we'll take that question, this started before that law entered.
Okay.
So this initiative was really to do something about it. Let's make these patients kind of more attractive to the doctor because it's going to help them manage their, their condition. And so when they come, they'll be better sort of prepared, more acceptable, more easy to manage. And then that law came, but still the doctors, and it's not for financial reasons because they're fee for service. They just find it difficult to cope with patients who, don't come always and don't understand.
Yeah. And it's also, the community health worker role is meant to also help them sort of graduate after so that the patients can end up being self-sufficient in the end. Yeah, empower them and probably show them the ropes. Yeah.
Thank you.
I'm just wondering about sort of system barriers. My brother lives on the Montreal South Shore. My mother's GP was happy to take him on, but she said, I can't. You have to go through the central intake system. So I'm wondering how much sort of friction there is in the system when in fact there are spots on one hand with physicians willing to take on new patients and through the barriers that the system puts in place. Now I don't know if this is
it's more related to where you're sitting on the list, right? It's more related to where you're sitting on the list. So there's people who've been sitting for years on the list, and so they want to get these people in, and as opposed to another.
I'm wondering how, how much a role that plays, and whether that particular rule is across the province, or is that a regional sort of health unit thing, or because it does cause. It's an additional barrier to access. I don't know if that's been sort of looked at.
No, it works. All the patients here are from the waiting list.
They're all from the waiting list already.
They're all on the waiting list.
Because there are stats, I think our vulnerabilities assessed through when they're put on the list, and then physicians can know where they are in terms of vulnerabilities. So there's some sort of cherry picking.
You think there's cherry picking on the list?
When the physicians are told, here's the next patients on the list, well, I don't want that one, I'll take this one. So, it's happening.
So I thought it was interesting that you've got, because there's a parallel in mental health. So if I have a patient with mental health issues and can't get here, if they have a community support worker to bring them to the office, they're more likely to get there. So I think, this is different barriers, but certainly already in the mental health. The other comment would be about your brother, is that we do know in our system that people who are at a higher level can navigate the system, jump queues, and manage to get forward than the people who are vulnerable. They have more difficulty with the system. What is interesting, and this is something nobody wants in Ontario, but you know, when I started my practice, I went to Healthcare Connect. Everybody went, ooh, you're going to get difficult patients. In fact, I limited the geography. So what had happened was I got a good mix of patients because I got some vulnerable patients, but there were those people who've been on the list 3 or 4 years that aren't urgent, and they also became my patients just because I just limited the geography. I wanted people to be able to access the clinic and not be 4 bus rides away from me. But you know, we have examples in England where that works. But our citizenship wants to choose. So, and our politicians will not challenge that, you know. So it's an interesting thing. But I do think the vulnerability piece, it comes out, it's very interesting because, of course, we've had this same issue with Syrian refugees, the whole issue of how do they get here if they don't know how to navigate the system.
Okay, thank you.
So we did a scoping review, PhD student, and I'm looking at community health workers. The issue is that community health workers, we had to do a scoping review because we couldn't even do a realist review because community health workers are implemented in so many different ways. So I'm curious as to whether or not these were paid or not, were they, you know, and because I think that they're an incredible intervention to level out the social capital that patients have. Because patients with social capital, you know, can navigate and get into the system, and vulnerable patients don't have that social capital, so community health workers are a really important intervention to help vulnerable patients navigate systems. And so I'm just curious about a little bit of the background about the community health workers and how they were paid and, you know, what level of education that they had, because it's so variable in Canada.
Yes, that's one thing.
So we usually review, by the way. Absolutely, it was a foundation.
This is what we found out. And that's what it's like. I mean, this is another thing that's so frustrating and perplexing in Canada. Here's another cadre of worker that we do not utilize well. And tons of community health workers in the United States really helping with vulnerable populations. At the World Health Assembly, it was like all about community health workers. This is where we need to invest, not more doctors and nurses, which can be controversial, but they said we need to have more community health workers, and we're way behind. So tell me a little bit about that.
Yes, so most of them, well, it's true that Canada just even we don't know how to refer to these people. There's so many different names and all sorts of things. So most of our literature actually came from US and Australia as well. But most of them tended to be volunteers. There were some that were paid, but they were from the community. But I know in the Quebec context, they're going to use an existing health professional role and like a social worker who's going to do the community health worker activities. So they'll implement that in an existing role. So I think that's going to bridge the capital.
I think unless there's a burning question, we should hear about the other 2 as well. So.
Okay, thank you.
Because ours ties in the back.
Yeah, no, I think this is good. I think we're okay with time. It's good. I think we're till 9:30.
Yeah, until 9:30.
So that's okay.
Okay, great.
So hi, I'm Caroline. We had another review in Lethbridge in Alberta. So the local stakeholders, they talked with their community, and what came out is that in North Lethbridge, the primary healthcare services are fragmented. They cater to only specific populations, and also the vulnerable populations think that they tend to be unwelcoming. So the local team was interested in knowing if they were interested in an intervention that would include a partnership between all of these local community organizations, overseen by the academics, and whether they can get together and offer mobile services that would go to different areas of North Lethbridge. So we identified 2,331 studies We included 11.
Well done.
I love that exclusion.
My question in a realist review, how do you go from over 2,000 to 11? What kind of criteria did you use?
Yeah, so there had to be primary care, so primary health care, and then in combination with one community organization. So right there wasn't that much in the literature. Also, so there's two main elements. So there would be the coalition and partnerships that we looked at, and also this mobile service. So it had to be a combination of those. Okay. So that's how we went to 11. So it includes systematic reviews, half and half. So half systematic reviews, half trials, RCTs, cluster RCTs, and as well one case control study. So the emerging themes. So what came up from these studies? So first of all, that tailoring materials and services decrease barriers to primary health care. So for materials, for example, it's written instructions, newsletters, and for services, for example, providing interpreters would help that. Tailoring the models of care for the people who need those care. So the second theme, services offered where the vulnerable populations gather, increases the reach of the intervention, and this was done in two ways. So first of all, there was a mobile service, so really, for example, a van that would travel to different areas. The other way was for pop-up services. So you would have this partnerships of community health and social organizations that would go to events or different areas in the community for this, where the vulnerable populations already are. And so the third theme, so partnerships and collaborations lead to positive health outcomes for vulnerable populations. So this was really obvious in the literature. The only thing though is that these types of intervention take a long time, so it's a long-term commitment and it's years. So they were talking about 3 or 4 or 5 year commitments on the part of the leaders. So you really need to have committed stakeholders in those partnerships.
So this is partnerships between who?
So in the literature, or
well, different service delivery folks, or
yeah, so health and social. So you can have newcomer services, primary health care services, elderly, even just community organizations, thinking like Millsong, Wheels, that sort of thing. So yeah, and so in Alberta, so as I mentioned, it's going to be an academic, but they're going to oversee the partnerships. So I think that's it for, are there any questions for this review?
When you did the reduction from 2000 to 11, and so you're looking at a context, a very specific context, like North Lethbridge, are you using exclusion criteria that that the studies are going to look at environments that are similar to North Lethbridge, or looking at similar vulnerable populations to North Lethbridge? So again, I'm just wondering how it translates, or is it just that you looked at the literature, these are some of the themes, and then in the deliberations using the realist review, you had conversations about what can we take from these studies, very different contexts?
We did well, for the limitation, so of course, we limited to high-income countries, so there was a lot in the literature, especially on mobile services in low-income countries, but we decided to limit it to high-income countries, and not many other limitations in terms of context.
But I think you said this earlier about we really spent a lot of time on all of the projects trying to think of a primary healthcare relevant context.
Yes.
So that was the context we were looking for, but we weren't looking for like Alberta context.
No.
So we were looking at international literature from high-income countries. So I think that was it. But if it was anything to do with specialty care, or there's a lot of programs being run by specialty, because obviously money in the specialty field, so they have their outreach programs everywhere. So those ones were all excluded.
Yeah.
So we decided not to do it.
Yeah, the limitation to high-income countries is because you're trying to transpose it to Canada, high-income country. But I'm just wondering whether or not you lose out on some south to north innovation transfer with that. I think there's something that we can learn. Particularly, North Lethbridge is not rural. I mean, it's city. But I think that we could learn a lot from Southern innovations in Indigenous itself, particularly the rural areas.
Right. That's a discussion we've had too. It's a potential other avenue as well to look at.
But there's a feasibility issue on some of these as well. I think some of our concerns, we had like sometimes like a 1 or 2 month timeline to go through certain things. And the other limitation which we kind of said but maybe wasn't really obvious, which we could be criticized for, was that we actually focused on systematic reviews in randomized controlled trials, and we also allowed 1 or 2 other studies to be brought in by the stakeholders if they felt this was relevant. So this is the ideal world. I mean, ideal world we would actually be even broader with our studies. We would be going to the developing countries too, and this would be a little bit longer selection process. Really, this is just the reality.
Barb, Diane, and then we'll go to the next one.
Just in terms of the process of selecting the articles, did you use, a very systematic process with 2 reviewers independently reviewing the abstract?
Absolutely. 2 people screened all those 2,300.
Right. Yeah, I just wondered maybe a comment about whether that is the more appropriate approach for a realist review, or whether people are using more of a rapid review method where they just have a single person doing that work.
Yeah, we did the process of this as well. So we had
specialists.
Yeah.
I mean, people can do reviews with 1 person. It has. I think most of us would agree that when you have a second person and you have a third person, when you have a conflict, you can resolve it. This is kind of like a nice standard. So if you can achieve that, but I know people have done reviews without that, and it doesn't. Like a lot of social science reviews, I'm pretty sure don't have 2 reviewers. It's kind of came from Cochrane, so I'm not sure that it's actually necessary. If you actually are really diligent and you know your area and you look really hard, I don't know if it's much different. I don't know if anyone else knows if there is much, what the level of difference would be.
Well, just in one of the reviews that we did, I mean, we had 3 people reviewing the literature because we had much broader inclusion criteria. So in order to manage all of that data, we had 3 people reviewing, and so they all reviewed the same 50 and calibrate it. And then we would check in, and then there would always be something that would go into we need to check this one, we're not exactly sure. But generally speaking, the bulk of the literature was reviewed by 1 person after this kind of calibration. So that's a way that you can do it without having everybody review, or let 2 people review everything.
Thanks, Diane.
Well, I have to admit that this is the first time I've ever heard the word realist review, but I like the term. Because being a family doctor and practical, everything has to be practical. One of the things that struck me is that we go to the literature. And when you were presenting today, I remember online demonstrations. So there's a YouTube about a program in Northern Ontario where they send out the vans and they set it up. So it was just, and they go to the community health center, they set up an elderly in the library or community center, and they have their little, and they do all foot care, and in fact, the reason they do it is because they need to do it. Right? They can't actually bring all those people into Thunder Bay, but it's part of the context. So I like the idea of this, thinking about the context, but I guess I wonder how these demonstrations get into your realist reviews.
Well, if they're not published.
Right.
But I think the intent would have been, honestly, I think if you have the time and money, we absolutely need to go to the actual implemented approaches, not just the studies, because this is where you get the richness.
So I just, again, task force now, the UN task force is going to be criticized, if not already this week, in the next few weeks, about not using enough grey literature for harms and interventions.
Yeah.
We could also have the same thing here. You guys didn't use enough grey literature. There are new methods for grey literature. It scares me still. Yeah. As someone has to fund these things, but so yes, I think that ultimately the things are getting better, like search engines or ways to kind of figure this out. But it is a little bit time consuming and.
Well, I think it's that explosion of information, and we tell ourselves we can only go to the published literature, which is peer-reviewed, but there is a huge amount of material out there now in, online, and people sharing, and it is that ability to filter it, because some of it's crap, and we have to be able to do that, but some of it can be inspirational, and perhaps the folks in Thunder Bay aren't academics that want to publish this in a way that can help spread it, but they actually have a demonstration project that shows some benefit. So it's just about that realist piece. What's the context?
Yeah, I think especially for a realist review, it's because in fact, there's a lot of stuff we didn't find, so we are basing this on the REAIM framework, which includes reach, effectiveness, implementation, so with the fidelity of the implementation, the adoption, the maintenance, and all these things are not reported in the scientific literature. It's all about efficacy. So you're right, we did miss a lot of things that are part of.
I would just say, though, to be fair, in the broader impact project, prefacing the realist review was a scoping review, which did include the grey literature, and a survey was sent out in all the regions to have anybody provide input about programs that they knew were going on or that they had been involved in. So I think that was incorporated. It wasn't reviewed in this systematic way, but it was included in the sense that the individuals in each of the regions who had to come up with a potential review question for the realist review did have that prior knowledge of the breadth of programs that were out there that were beyond the literature. So that was included to some extent, but didn't have that systematic approach.
I think we should go to the next. Thank you. Okay, so I'll be quite quick. I know a number of you in the room have heard about the Ottawa component of the impact project. And so the local context here in Ottawa is that we found out from stakeholder engagement that in terms of increasing access to primary health care for vulnerable populations, that providers and other stakeholders felt that they needed support in terms of being able to address their patients' primary health care needs, but didn't always have the time and didn't know that resources were available. So they really didn't have a good grasp of the breadth of resources, and as a result weren't referring regularly to those community resources to help people address their health needs, but also to address their social needs that was out there. So when we spoke to representatives from the LIN, they said, well, we don't want to invest in new programs. What we want to do is better connect people from primary care to community resources, and we think that we can do that because most patients in our context have a primary care provider. So how can we increase primary care providers' referral to those community resources? And there's a fair amount of literature that says only about 20% of the time do providers recommend a program in the community that a patient can attend to address some of their health needs. So what we then asked the realist review team to do was to look at what organizational changes could be implemented within primary care practices to increase providers' referral to community resources. So the systematic research and selection was conducted by Caroline and Micere, taking the lead on that. And it was, I think I will speak to the fact that there was that back and forth. So I was the coordinator. I wasn't involved in the review, but was able to then provide the feedback and context as they went through the review to understand whether the search criteria was appropriate, whether the way we selected the interventions, whether it would be appropriate in our context. So it really was a team effort in that way. So in terms of what we found, that when we worked with the realist review team, we were able to think about, well, we know that our intervention needs to involve educating or training providers about what's out there, but we also need to think about processes that we can implement to help increase or support referrals to community resources. So the themes that came out, like the other regions that you saw, there were about 4 key themes. The first one was how to train providers about resources. And what we learned from the review is that we needed to tailor the training duration, the content, and the tools to meet practice and patient needs. So there was no one-size-fits-all that we could implement in every practice. We would need to work interactively with the practice to determine what they needed to support referral. We also learned that having a formal connection between a primary care practice and community resources or a particular program will help support referral because the provider feels that they're referring to a reputable resource that they have a relationship and an ongoing communication with.
We learned that the role of a champion within the practice was key. So someone in the practice who really believes in this initiative to increase referrals to community resources would support implementation and success of this intervention, because that person acts as a champion to their peers in a way that's much more effective than just a researcher who's coming in and implementing this intervention. So we need to have people on board within the practice to support it. Making use of electronic health records was recommended by the Realist Review. That in the studies that had the greatest success, as they said, if they could embed something within the electronic health record to cue the provider to ask about community resources or to provide the direct referral to that resource, would support that referral, because it just makes it easier and less time consuming to search through things or to remember to refer the patient as part of that patient encounter. And then identifying processes that support referral. One of the key things that came out was having print or electronic materials that included the benefits of attending a community resource, as well as information about available resources would support referral. And that could be available to patients, so in the waiting room, for example, or to providers. So patients seeing it in the waiting room may prompt the referral from the provider, can you send me to this program? But it also, having the provider have something in front of them, they have an ongoing queue that can support their referral. Okay. That's great. So, well, maybe just a few more minutes for discussion. Maybe what I'd like to just point out is that these are, or rapid realist review, intended to really inform an actual initiative. So they were done because somebody needed to do something and needed to be informed. So that's great, that's really exciting. But on the other hand, Kevin will remember how much it was a challenge, because the need of our stakeholders, our regions, kept shifting. So, well, no, not quite that, but we need this, and then, so we were trying to chase a moving target. So that was a bit of a challenge, but it is very rewarding to know that. And in fact, a lot of the elements for Ottawa that Danielle reviewed are going to be incorporated in our intervention. So we are going to use these. So we're going to, the material, we're going to have promotional material in the waiting room, EHR, as much as they're willing to include in their records, we're going to do that. We're going to have a champion, and then, yeah, I mean, essentially, all the aspects we're going to make sure we focus on to ensure better referral.
So the rapid realist reviews were to inform the interventions that would then go into the system that you would study.
Exactly.
Okay, so yeah, that's relevant.
And there was also good sort of cross-fertilization among the realist reviews, because what we're describing here is only one component of our intervention. Our other component is implementing patient navigation to help patients reach the resources if they face particular social barriers. So definitely the Montreal Review and understanding community health workers then will feed back to us, because we can share those lessons learned.
I have a question, a technical question about the doing of the reviews. I guess it was from the Calgary one, there were, you said you were focused on systematic reviews and RCTs, etc. What if the RCT is referenced in one of the systematic reviews? Does that matter?
I'll leave it to the team to...
Yes and no. So they were sometimes with reference, but we were looking at higher level data coming from so not exactly going to the single studies that were included in the review, but more of the higher level, what the reviewers are saying about when you put all these together. So,
well, I think so. There's one, I can't remember dates for our limitation. So one of the concepts with systematic reviews now is if we actually could trust this method in science, we wouldn't have to go back more than 5 or 10 years anymore, or less and less. This is one of the things. So one of the reviews had 100 RCTs in it, or let's say most of them were RCTs. And those would have been published over the last number of years. So they wouldn't have come up in our search. We were looking for more new RCTs, or RCTs that weren't answered in the reviews. So I think the review was the main building block for evidence. And then you could actually, then we did have debate, and this could be debated. Do you break that review up on all, like if you could do spend a very bit of time for 100, that one scared us. There were usually they had like 10 or 15, so weren't too bad. That one had a lot of, so that would be a fair effort to actually go back to all those studies. Then you have 100 to look through. So we didn't do that. We decided not to. But we decided to use the reviewer's synthesis, and the limitations that brings back.
If I could add to that, remember that the objective here is not to get a meta-analysis and one sort of a score of the effectiveness.
It doesn't matter.
Exactly, it's more about things.
Yeah.
So it didn't really matter that something was included. We were looking everywhere for clues about what to do well.
And I still like to think we tried to work with the stakeholders with their emerging, we call it emerging themes because we were working to ask them what they had the summaries of the articles. We have a report for our project, and we were sharing this the whole time. And we're trying to see, well, what resonates with you as well? This is what we thought we saw, but we're the researchers. What do you guys think you saw? And we tried to use it like that. So you wouldn't normally do that in a systematic Cochrane review. In this case, we thought that was the way to do it because we were hoping for practicality. In a way, building, I think we were getting buy-in for the intervention. So I think hopefully the intervention will have better buy-in now so that people will say, oh yeah, we looked at all those issues, I feel like we're doing the right thing. So I think it's partly getting buy-in for future intervention.
So maybe one more question and then we'll go over.
Have you been in touch with HealthLinks? Because when I'm looking at this, like I have a student who's mapping out all of the community resources in the Champlain Lynn, including pet walking. Because one of our low-income members, we can't give them a dog, but like,
so that's interesting. So we should talk. We definitely. We're actually one of our main stakeholders is the LIN, and so we've got the primary care lead there. And so, and our patient population is not the HealthLink patients. It's not the really medically complex patient. It's the average person who, maybe elderly, falls prevention, or immigrant. So it's not
there might
really
be some overlap.
There definitely is, and it's unfortunate that there isn't a central repository of that. Now, there's the 211 that has a lot of these, but everybody who's working in the area is building on that. But where do we go to learn? So we should connect about what your student is finding.
Yeah, I think this is the reality here when we start talking about this. This used to be the blue book for Ottawa.
That's what it is.
But the trouble is that this becomes so extensive, no one can build on it very well. So it kind of becomes like overwhelming. And I kind of like that Ottawa had some of the top policymaker people involved. And right or wrong, they kind of felt that this is their real critical issue. So in a way, it's that situation where you have lots of things you could do. How do you prioritize? How do you focus? How do you move forward? Because it's just getting a bit overwhelming for these different services now. So I sense that they thought we have all these services and no one even goes to them. So that was where it came back to. So how do we at least make sure that some of the services are getting linked? That was what was kind of the.
Okay, so we'll take a break, and we will come back at 9:36. 5 minutes, because we don't want to take any time away from Sarah.